intercostals do? What does the diaphragm do? What is the role of muscles like the scalenes? And then what are the role of the muscles of external, or like the muscles of forced inspiration, such as pectoralis minor and so on, in elevating the upper part of the rib cage? Because, of course, all of these movements are going to be predicated upon how efficient is the muscle mechanism to produce this. And this might be part of what we've got to investigate in terms of rib movements, particularly if we're working in a place where there are respiratory problems. I was hoping to see a number of, asthmatics and people with basic chest problems. I mean, this was a huge field in physiotherapy in Britain. I mean, there was no such thing in those days, and I don't know what is the development now in people like respiratory technologists. Physical therapists did everything. And so, you used to have a lot of bronchitics and a lot of asthmatics and a lot of emphysematous patients, and we didn't have at that time any program for seeing if you could alter motions within the chest to see if it would make any difference to the visceral organs related to respiration. And it would have been interesting to see, can I mobilize these? But the more I think about the provision of oxygen and the removal of metabolites to tissues, and of course the entry and exit points become very important, we've got to think about the importance of vascularity and the importance of respiration to cells. Because without that, they're not going to function very well, and without it at all, of course, they're going to die. And so perhaps this alteration of movement here is very important. If you look at any of the schemes that go back into antiquity about good living and all this, deep breathing and breathing patterns are very much a basic part of all of those programs. Whether you go from the Eastern kind of mystics to the sort of Western equivalents of these. And my feeling about all this is that if there is a sort of like a common trend which you can see in all kinds of societies, probably that thing is very important to do. And so that a business with respiration is important, and perhaps we can be materially concerned with the improvement of those respiratory excursions. Another thing that we could have put on, I mean, it goes, you see, now we're into the sort of thought processes, how your brain goes. Another thing that we could have put in there as 6, or if we'd had Buzan's thing, it would have come out anyway, is to think about the input that we're getting from the mechanoreceptors of these joints. So that could be number 6 here. What Weick found was that the mechanoreceptors in the costo-transverse joint, and I'm not sure about the costo-vertebral joint, but let's just put it in this rib vertebral complex here, was extremely important for signaling when to stop the inspiratory excursion. And that in people that had osteoarthritis or osteoarthrosis of these joints, the mechanoreceptor trigger was set at a much lower level. So you breathed in and stopped and breathed out, so that the respiratory excursion was much less efficient. Not just because of the osteoarthrosis, but because of the trigger into the central nervous system that this joint has reached the limit of its movement, even if it hadn't done. So that mechanoreceptor signal is important. Then you go on to the next phase of this business of respiration, and you ask yourself, well, it seems a bad thing not to provide oxygen, to let carbon dioxide levels start to rise in the blood, and it is a bad thing because the raise of carbon dioxide in the blood is a very potent mediator of pain mechanisms. This is why people, when they are, this tension thing, and taking short, shallow breaths, okay, and blowing off oxygen and so on, increasing carbon dioxide levels in the blood, that is a very potent mediator of pain. So this whole system is kind of like a self-fulfilling prophecy. We don't breathe as much, we pant a bit more, we don't ventilate properly, the carbon dioxide levels go up, any pain that we have is now greater, so it triggers off this mechanism. Now we get tension in all sorts of muscles, now we're building up more carbon dioxide from muscle metabolism and so on. And we're into a flight and fight kind of response now. So this is very profound in its effect, and perhaps to treat the ribs in rather more of a very important thing, other than just as a sort of an extension of the thoracic spine, might be for you to develop. But not for this course, because we're just going to move these things about. But if we can move them about and then go into general movements, this will be a very, very important thing for many patients. So, let's see where we go as far as the very brief review of the anatomy. Not very much at all, and you can look this up at a later time. I want to act a little bit as a devil's advocate here. Here's a picture, of course, from Kapanji. And what I'd like to just show on the board here is just one or two things, is that we look at the two joints that are concerned with the vertebra, the costovertebral joint and the costotransverse. The shape of the rib surface was what? Male. So it was convex. So that any movement that occurs there is going to be reflected in an angular movement of the rest of the rib in the opposite direction. So that if the neck goes into a posterior rotation, we're going to sort of have like an elevation at the other end. So if this goes that way, then this is going to swing upwards. So the inspiratory movement is going to be related to a downward movement of these male surfaces at the costotransverse and the costovertebral joint, or certainly at the costotransverse, and probably a bit of a spin at the costovertebral joint. And of course, inspiration will be the opposite of that. Now, let's just have a look very briefly, but in a challenging way, at the ligaments here. This area has an enormous number of ligaments. We've got the ligaments that attach the head to the vertebra above and below and the disc. And this is called what? It radiates out from the head. The radiate ligament. I mean, anatomists were logical, if nothing else. But also within this radiate ligament arrangement, okay, we've got a deep ligament that attaches the head to the disc, which would seem reasonable. And so this is an intra-articular ligament. So we've got a radiate ligament and a special intra-articular ligament that is attaching that head of the rib to the disc there. Then we run out along the transverse process and the neck of the rib here, and we see that there are at least 3 or 4 ligaments attaching here. We've got the one between the transverse process and the neck, short little fibers, but keeping the neck and the transverse ligament together. Then we've got the capsule of the costotransverse joint. Then we have got a lateral ligament, which we can see here. And then if we come down to the diagram here, we can see that there is a fairly strong ligament that goes from the neck to the transverse process above. That's got to be an enormously complicated and involved ligamentous structure. So we can see that the costotransverse ligaments then, there are 3 of them. There's the costotransverse ligament proper there. Then we've got the lateral costotransverse ligament at the outer part of the capsule, and then from the neck and going up to the transverse process above, we've got the superior costotransverse ligament. So this is very, very complicated for such a small area. So obviously there's a lot of control there about what goes on. And what I'd like you to ask yourself is that when you go on courses and people talk about the rib going into a posterior displacement and an anterior displacement, oh geez, and I can feel this, it's 1/4 of an inch back. How can that occur with this? Unless there's been a major disruption and a little bit of kind of pushing the arm out to sort of get the rib to go from an anterior position to a more posterior position, you'd feel that perhaps we're stretching credulity a little bit to sort of look at this. This is a pretty good mechanism. So that's a thing I think that we could just think about and look at and challenge ourselves from the point of view of what people say about these ligaments. Now here's a pretty scruffy diagram which I apologize for. In fact, I hesitate even to put it on. But it's been with me a long time. And I mean, it was even done before the days of permanent inks. So here you see my sweaty fingers having removed the ink. Okay, taken from Gray's Anatomy, the English grade, so you can get this. And I've only left it in, and I really should smarten it up a little bit here, is to look at this. That if we take the direction of the costotransverse joint here, we can see that the direction is a little bit different from the upper 5 or 6 to the lower ones here. And that when we're looking in the upper part, the ones that have a sternal connection, essentially the joint is fairly well in a coronal plane. So it's gently curved, but in a coronal plane. When we get lower down, the joint becomes much more superior on the transverse process. And that obviously reflects a difference in how these bones move. The ones that are arranged like this on the transverse process, you can imagine that what's going to happen is that as this descends down this sort of track like this, we're going to get a rotation like this, which is going to get us an elevation of the ribs anteriorly. So that would be the inspiratory movement. And of course that is called, in the upper ribs, the pump handle movement. When we come to these lower ones and it's arranged much more superiorly, the movement there is a movement which will tend to reduce the angle, the xiphisternal angle here. So we've got to kind of think of this kind of movement happening in the lower ribs and a little bit of a movement like this almost, backwards. So we've got a different movement, and of course that is the bucket handle movement that occurs below. Now I know that in muscle energy, they sort of have that all ribs have some degree of pump handle and all degree of bucket handle. But if we were to look at where they are the most noticeable, then the pump handle are on the sternal ribs and the bucket handle, as we all know, are on the chondral ribs at the bottom. Diane, and I will acknowledge these with gratitude, although she doesn't know I've got them, has done some excellent diagrams. I mean, look at the difference between this and this. And I think that represents perhaps the difference between the masculine and the feminine. A very interesting thing in Canada. When we developed this whole thing, and I think you're going through this a little bit at the moment according to Chris here, and this is the masculine-feminine thing that we used to have. We had this whole thing going, and it was mostly men to start with, I must say, that started this off, and we used to sort of create policy in the pub at night, all right? Nobody wrote anything down, and we all kind of talked a lot, and you know, it was kind of good brainstorming stuff. And then we had one or two of the women qualified, and so they were in on the meetings, and immediately we became totally organized. They wanted us to get stuff down, let's have it down there, we want it in a policy so we can look back. And it was a very great trauma to us to have to make these decisions. I mean, we kind of liked just throwing ideas off. I mean, there was no threat to us, nobody could come back. Oh, you misunderstood me. Let's have later time. So here we see this, look at that beautiful, beautiful diagram. And so what we're doing here is we're seeing that this movement, which is related to flexion of the spine, of course, she's talking about here. But flexion goes with expiration, doesn't it? And you can see that as she's describing this, there's an upward movement here with this flexion of the spine, which forces the rib into an expiratory movement. But of course, when we're thinking of rib movement alone, we think of the rib movement perhaps driving the thoracic movement to some extent. through the internal intercostals and through the diaphragm. And so that as we go into extension, or as the rib goes into a posterior rotation, the upward part here rises up. And so that's giving us that pump handle movement with this motion here.
So the dotted line represents where it started?
Yes, I looked at this myself. The dotted line is the starting point, and this is the end point. Yeah. Yes, sir.
Yeah, could you put your diagram up? I understand that better.
Okay, good-o. Very good. Like my wife said to me the other day, you know what really bothers me? She said, I just cannot stand this living in chaos all the time. All right, so this is the diagram for extension, flexion, inspiration, expiration movements. Now, I don't want to say a lot more about this because I think we've actually sort of covered the real kernel of what we need to do. But just let's go to the front end here. And what did you have when we thought about the anterior parts of the ribs? Here's a picture from probably Kapanji, I think, and we can see once again the sort of difference between bucket handle as we look at the angle change with the more superior part here, and where we are in the classic area here of a pump handle movement. And of course, when we do the pump handle movement, because of its attachment to the sternum, it's going to have to push the sternum outwards. Now then, what's your sort of feelings? Listen to me, see how I'm talking? Your feelings? What's your feelings about, or your mental processes about movement of the ribs and how the ribs articulate anteriorly? We've got a chondral attachment to the ribs in everywhere, haven't we? And remember, this is not a proper joint. It's a small socket on the rib, and then the chondrium fastens into that small socket, almost as if we've had a kind of difference in ossification here. And that sort of fits like this without a capsule, and then we've got a periosteal kind of thickening over that area here. So this would give us the costochondral attachment with just the end of the rib with a depression in, and that fits a convex part of the chondrium, and then we go with the chondrium to the sternum. Now, in general terms, where the costal cartilage goes into the sternum, there is a little synovial joint, with one exception. And one difference. The one exception is at the first rib, which has the same kind of attachment as the rib to the chondrium. No joint surface, so it just goes in to the periosteum of the manubrium. When we come down to the joint of the second rib attaches at that point where the manubrium and the sternum attach. And remember, the manubrium and the sternum form what kind of a joint? Secondary cartilaginous joint. It's got the great similarities to the intervertebral discs. In other words, it has a kind of an annulus and a slight nucleus. So it's a secondary cartilaginous joint attached by a disc, the center of which can often be differentiated as different from the surrounding structures. That's the characteristic of a secondary cartilaginous joint, isn't it? Now then, at that point, of course, where that attaches in, we've got the bone above, the bone below, and a little attachment to where the rib is, just the same as at the back side. And at that point, there is also two little synovial cavities, where it attaches to the manubrium, where it attaches to the sternum, and then it's sort of separated where the manubrio-sternal junction is. Somewhere in here I have a picture of that, but I think it might be in a group of pictures that I was doing with the ring system, and so we can see that at a later time. Now then, how about the interchondral joints, which we're talking about here from the low ones down? There was a skeleton, wasn't there, with a... Yes, thanks, Anne. Thanks. So we're talking now about this little joint here, okay? And this one is also a synovial joint. So we've got this costochondral joint, non-synovial. We've got a little synovial joint, mostly where the chondrium comes in to the sternum. Where the second rib comes round here, we've got a small synovial joint on both sides, and then a little interconnection between where the manubriosternal disc is. This one is fairly similar. This is a costochondral articulation, same as everywhere else, but this is also very similar, that it doesn't usually have a little synovial, which probably relates how much movement takes place there. And perhaps if I wanted to be a real devil's advocate, I'd say, that seems to me that not very much movement occurs if we don't have a synovial joint there, because synovial joints tend to go with movement. And if we've got this joint here, if I wanted to be a devil's advocate, I might say to you, how much movement occurs there? I mean, it's very important, because when we breathe and this sort of moves out like that, we've got to get some degree of movement, of rocking between the manubrium and the sternum. About 6 degrees takes place between full inspiration and full expiration of movement, so it's very small. Now, I would ask you the question, and I think we've really got to try and sort this out. If we're talking to a group of orthopedists or respiratory internists or whatever, and we're saying to them, look, we really believe that this bone here can move on the sternum. And it can do a whole variety of things. It can side flex, and it can rotate, as well as flex and extend, which has been a fairly proven fact over the years. But you remember, in 30% of people over a certain age, this joint totally fuses. So, is it possible with this very thin joint that we can get a whole variety of measurable changes that we can feel from the outside? Now, I'm not saying it doesn't take place, but I think that we should sort of really challenge ourselves to try and prove this. Would it be possible to go and see a radiologist and say, look, I want to just do a little study here with a cineradiography, an image intensification, so you're not getting very much RADS. And just let me see, can I do this? I did a little thing with the lumbar spine to prove what all these movements were, and of course, you know, nobody takes any notice of these things, because you move and you move in relationship to all these, the machine, and so the angles are different, and what are you viewing then? These are the problems with all this, but perhaps a radiologist could sort of fix this. I'd spoken to a phys med guy, and I'd said, you know, how could we put some markers in here? We'd originally, with Cliff Fowler and I, put some sort of pins into the posterior ilium while we'd done this, just hypodermics. I mean, it was, you know, just a little surface thing and bang them in. It was not all that painful. And he was sort of talking, could you place in kind of a little bit of stuff, perhaps like pantopake or something like that, in the periosteum, so that it kind of stayed there. And so that when you did this, you could watch what happened to this radio-opaque material rather than putting metal in there. But you'd think even just doing these things, you should be able to see something happen here. And if we could do it with a cineradiography, perhaps we'd be in a position to sort of argue a little bit about this. I know I was going to bring a set of tapes that I got from Ola Grimsby just on peripheral joint motion, and he persuaded his wife to go and have all this radiation. And they've done a whole series of little videos on motions in the hand, but it wasn't all that clear, and he was sort of pointing out, you can see how this happened. I'm blowed if I could see how it happened when I was watching these videos, so I didn't bring it with me. But, you know, I think that some of these studies require to be done. Just to challenge ourselves and not just write down this happens. Because there's no question. When you believe it happens, you feel it happens. And we've all felt that. But if you can feel cranial sutures moving, we should be able to feel these other things moving. I'm not saying I can feel those moving, I'll tell you. But some people say they can. And I think sometimes we don't necessarily feel a movement, but we feel a change in tissue. And that might be just as important. So that's the challenge. So when we look at this area, I think we've got to look at what is, then what we can do, and then we've got to speculate a little bit about a whole variety of stuff around the ring system here and its relationship to the shoulder girdle. But remember that going from what's known to extrapolating kind of like thought processes doesn't necessarily mean that any of those thought processes are correct. That requires verification, and that's the challenge. To have the ideas and then to verify to see whether they are correct or not. Not for it just to become part of the folklore. So here's the challenge for you. Okay, so what would an examination look like to perhaps test out some of these various features? Well, I think if we look at this, we could see to ourselves that we can examine in a fairly clear-cut way the rib excursions, and we can perhaps objectively measure through a spirometer or some of that thing, or the right peak flow meter system, what we have got as far as inspiratory and expiratory volumes. When I was down in Iowa, Tom Wheatley gave me a thing from the hospital that they'd kind of junked and he'd saved on his shelf, but then they'd gone to a computerized study thing, and he gave me this little volume measure, and I started doing this. But you know how unpleasant it is for patients, and you've got to like this. I feel I'm going to pass out. So, wow. I can even see black spots before my eyes now with this sort of process. But you know, that would be an easy thing to say, geez. That would be an easy thing. I think somebody better sort of mobilize my chest this morning to just see if we could improve those kinds of measurable volumes. You know, that would be an easy enough thing to do. Now, when we look at this, I think there are a number of things. We can see that we could measure the general feeling of where the rib is moving. That would be reasonably easy. You know, and split it into like the traditional things for superior apical, mid-costal, inferior basal, posterior basal breathing. We could feel that, and I'll write all these up. That's one thing. We could also feel that perhaps it would be important to try and feel, because we want to take everything into consideration, positional faults. Then we could go between the ribs and feel, when we do a motion like this, whether in fact the ribs are moving in the approved fashion with the bucket handle and the pump handle movement. That would seem reasonable to do. We could perhaps check a little bit the efficiency of the muscular system, of which of course the diaphragm constitutes what, 60-65% of the force that moves the rib cage around. We could perhaps check out the expiratory muscles, largely of which it's a relaxation of the